But let's face it, simulation is not a new tool. Simulation has been out there for many, many years, and I think there's a fundamental or foundational work in simulation-based high-stakes application. And let us view the life support world, which is considered to be a high-stakes component in certification. We are expected, as a part of our employment, to have valid certification in BLS, ACLS, APLS, NRP, and many others. And this is well established within our culture already today, and is using, of course, the third-generation mannequins as well. The assessment component there is not as advanced as we want it to be, but we're certainly in good grounds there. Another movement that has really contributed to the culture of high-stakes assessment is the OSCE movement. It's pretty much matured in recent decade or two via the Medical Council of Canada assessment, OSCE licensure for exit-level graduates, the ECFMG's work, the National Board in 2004 applied it for local graduates here. Hong Kong, Japan, South Korea, European countries and others are all doing OSCEs this way or the other on a high-stakes level, mostly with standardized patients. But this is good foundation. We're seeing lately the selection and screening process of medical school candidates, pretty much inspired by the McMaster work of Howard Ryder and Kevin Eva. We're doing it now back in Israel in a different model, more simulation-based, but the idea is the same in terms of trying to look for the non-cognitive attributes that are so important in our profession. Some other foundational work, little is published in nursing, although there is a big tradition, long tradition of using simulation, using simulation over there, but not yet in high stakes. Dentistry has a long tradition of low fidelity simulation, even for selection on psychomotor skills and graduation. Applied health professionals are not yet published, have not yet published, but there's work at Mitchell and other places that deals with simulation on an institutional high-stakes level. Recent advances, again in spirit of Michael Gordon's lectureship, Harvey has matured in recent years to become part of an OSCE station in the Internal Medicine Royal College Canadian certification exam. Surgery is with us too. The surgical FLS, fundamental laparoscopic surgery, simulation-based low-tech exam, but high stakes. You cannot complete your residency without an FLS score, positive score. And recently I was informed that anesthesiology in the US, after 20 years of playing with simulators, since the David Gaba's launch in the early 90s, are now taking simulation as part 4 MOC, maintenance of certification. It's just a mandatory station, or a station that is being viewed as mandatory recertification component. No assessment there, but this is a good sign towards the future. So there are many driving forces out there, such as the patient safety movement that really pushes us to be more aware of the public demand for safer healthcare, and there is a link there. Mental link between safety and simulation. Accountability of medical education, a great article in BMJ 2 years ago that really charges us with, are we doing good enough job in the product line of healthcare professionals, and the maintenance of certification movement that is looking into more aspects of hands-on certifications. Accreditation bodies, as I mentioned before, are in the performance assessment paradigm these days more than ever. And the global migration of health professionals, let's face it, the fact that so many countries are attempting to be gatekeepers and let foreigners go into the system only after they're being checked was a driving force for the ECFMG. In Europe, there are some such driving forces. It does good eventually to the field as long as those regulatory bodies are applying it on their own local people as well eventually, as it happened here in the States. The simulation industry is more mature. They have more metrics built into the simulators, and the growing link between the soft skill OSCEs and the high-tech skill simulators is now working so much more better together in the hybrid model, and there's so much cross-fertilization that could be learned. And Barry Eisenberg mentioned the other day the Ottawa conference that was hosted by Miami University, all about high-stakes assessment or assessment of competencies. One theme group that I was on was dealing with technology-based assessment, including simulation, and medical teacher will soon publish a whole issue on assessment in the healthcare profession. Let us remind ourselves that it's not only about simulation. There are so many other simulation-based, non-simulation-based assessment tools like workplace assessment, portfolio assessment, 360, and many others. The art will be to kind of integrate simulation-based assessment and the many other legitimate and well-established tools. So with that in mind, when we look at simulation-based education, there's so many applications that are out there that all of us here in the room are doing, at least some of them. I would argue that the most important, the ultimate application of simulation-based training or simulation-based tools is the ultimate application of screening, licensure, and certification. Only when we will be there and adopt and integrate simulation also, not instead, but also as a certification tool, only then we'll be able to say, hey, we have matured, and perhaps we're reaching the cultural safety culture that aviation is, for example. Aviation simulation is not only for training, it's also for maintenance or certification and beyond. So with that in mind, we established MESSER exactly 9 years ago. I believe we are the only national resource level simulation center out there that really ambitiously is pushing the limits and the envelope towards comprehensive interdisciplinary multimodality simulation platform that is very much geared towards hands-on training, patient safety-related training, and of course, this concept of high-stakes performance assessment as a goal, as an explicit goal, to really push the standards in terms of quality and safety forward. So this is MESSER, the top 2 floors of this building, all types of simulators, all types of environments and settings, the audiovisual debriefing system that we are using, multidisciplinary staff with experts in all possible fields, from psychometrics into education and the medical fields as well. So what really guided us was really to have a simulation center that would work hand in hand with the regulators, those who really regulate new standards, like the Ministry of Health, Defense Force Medical Corps, professional associations, obviously. It's a non-profit body, but makes a point of being a fee-for-service and self-sustained eventually, because we all cannot afford ourselves to be dependent on the goodwill of CEOs and management and philanthropists. We need to find a model that really is sustainable for years to come. A lot of focus on the top-down model of train the trainer, train the raiders. Once again, in spirit of what Rona Flynn said, that it's not a matter of the newcomers only. It needs to be all-inclusive with the top-down model of cultural change. And what we're very proud of, which really leads to the simulation assessment, high-stakes assessment story, is our partnership with the Israeli National Institute for Testing and Evaluation, a very reputed body in Israel in terms of the measurement expertise, and they have been with us from day one and here in this conference as well. So we've trained by now over 90,000 trainees and examinees. We are the second largest employer of actors in Israel after the National Theater. We are running multiple national courses in many different fields, some of which have matured to become mandatory, not high-stakes assessment, but mandatory participation. The Israeli interns are blessed with a 5-day nightmare course as a requirement before they go into hospitals. They can't go into hospitals without coming for this nightmare course, which they tell us is the best nightmare they've ever seen in their lives. And a lot of work top-down, once again, with management, risk management, safety, CEOs and others who come to be trained on these soft skills, apology, disclosing errors, and beyond. And the mandatory train the trainer or train the raider policy has reached these numbers of over 4,000 people who have been trained by us for these tasks, and that's something that we believe is really the cultural change agents that we have disseminated throughout the country. So very briefly, I want to share with us 4 stories of high-stakes maturity, high-stakes programs that have matured into this very application. Anesthesiology board exam, Chaim Birkenstadt is here and is going to be talking, I believe, in the next session as he won the first prize in one of the categories. Chaim was courageous enough to apply simulation-based assessment in anesthesiology only 2 years after we opened our gates. And the decision was very much a decision of leadership rather than, a very natural evolution of long years of using simulators. No, it's not the case. And the decision was to use simulation as a complementary component to the traditional exam. We're not here to replace, we're here to augment different aspects of assessment. And it was a task-driven test, minimal requirements in 5 domains that you see here. A blueprint was a big piece of doing it, and you'll see it later on as well. What are the tasks? What are the domains? What is it that we want to test and we are not testing in the orals or the MCQs? All kinds of tasks were put together by the committee. Chest drain insertion. Anesthesiologists need to know how to do it, obviously. Have we checked it objectively? Not sure. Scoring with checklists, general holistic scores on the more soft skills like management and leadership and beyond. And candidates have been oriented at the Sim Center prior to the exam, obviously, to get exposed to the examination structure, mannequin simulator setup. And of course, the frequent errors are published. And same on the Train the Trainer, very structured courses for all the faculty that was recruited for the rating position, with refreshments on the day of the exam, something that we always do. And it evolved. We never fell in love with the first version that was issued, that was applied in 2003. Every year, the evolution brought about some improvements, such as, for example, the increased realism by standardized nurses that was applied later on, because anesthesiologists don't work alone in isolation. There is some assistance around with nursing. And since 2009, full-scale scenario followed by debriefing 20-minute scenarios that is very much a reflection of what anesthesiologists do, and then their insights in a debriefing model station. Thus far, over 500 examinees, over 100 trained raters. Think about that it's over 50% of Israeli registered anesthesiologists have been involved in this exam this way or the other. And it's amazing to see what changes it made in terms of some cultural effect. It has improved dramatically the board exams on orals and MCQs, because the structured approach to assessment was applied and fertilized other areas of assessment. And we are now doing train the rater workshops for the oral exam ratings. And we do it simulation-based train the rater workshops. We simulate oral exams and provide feedback to faculty on how do they abuse their poor examinees in the oral exams. And we research and publish quite a lot, and more to come, and more will be presented in this conference later on this very exam, as I mentioned before. I'm looking for that. Here we go. Paramedics joined the gang about a year later, and over 150 examinees annually with the Israeli regulatory body of paramedics. So the paramedics in Israel are also have also joined us, 3 paramedic schools, again in 2004, replacing the last kind of subjective megacode into a licensing OSCE that takes place at the Sim Center. Again, same model, exposure of the examinees a month before for a full formative day. They do a lot of simulation anywhere in the schools, but the structure is exposed again. Train the raters, same model, and exam days on different models according to a blueprint, cardiology, trauma, pediatrics, and others. 3 team members. The leader is the examinee. The 2 others are students from paramedic schools who are exposed there as well. Checklist, holistic scores, and beyond. And once again, big numbers, over 50% of Israeli paramedics have been exposed to this exam, either top-down or bottom-up. And they do view this as a very fair, authentic type of an exam all along. And they now believe that this is a big yes at the end of the day in terms of, do you believe that this should be the way to test?